We're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis Charter community of the Lower Mainland region. And wherever you are in the province, take some time to acknowledge the depth and breadth of the place and territory that you are on and the people on it as well. And as always, we respect the elders past, present, and future. Next slide. So Province-Wide Rounds is a collaborative effort by the University of British Columbia Division of Nephrology and BC Renal. It is generously supported by the sponsors that you see there, in addition to the health authorities, and truly integrated collaboration that allows us to have breadth and depth of speakers from around the province and the country, and sometimes outside the country as well. So we're very grateful for the ability to be able to do this. Next slide. So without further ado, I'd like to introduce Dr. Gaylene Hargrove, who is a clinical assistant professor at the Division of Nephrology at UBC, based in Victoria. Gaylene graduated from medical school at the University of Calgary and did her internal medicine and nephrology at the University of Calgary as well. She began her practice in Victoria in 1999 and did additional training in palliative care for kidney patients, and has facilitated numerous educational opportunities for Island Health Renal program over the last 20 years. She's been an active member of the BC Provincial Palliative Care Committee for 18 years and was appointed the chair in 2016. So without further ado, over to you, Gaylene. Thank you very much for the work that you do and the committee does, but importantly for sharing that with us today. So I'll hand it over and we'll come back at the end for questions.
Thank you so much for the kind introduction, Adira. I would like to open with my acknowledgement that I am giving this presentation from the unceded ancestral territory of the Lekwungen people of the Esquimalt and Songhees nations. I live on the unceded traditional territory of the Saanich nation, and with gratitude and humility, I appreciate the stewardship of the land, and also recognize that acknowledgement alone is not enough, and I strive within my work and my personal life to advocate for Indigenous peoples, to facilitate their healing, and to develop better relationship with them. Next slide, please. So, the Integrated Palliative Nephrology Project. I'll open with learning objectives of this presentation. This is specific to the IPN evaluation qualitative project, and this is part one, the patient interviews results. And I will expand upon what integrated palliative nephrology means. Welcome to all attendees, and if there are patient partners in attendance, a special welcome to you. And please feel free at the end to ask questions related to a palliative approach. I'm more than happy to speak further to that, but I do want to lay the foundation for what a palliative approach is. So we want to inform healthcare providers today involved in the care of CKD patients across BC about reported patient perspectives. Sorry, Sidoni, go back just a moment, please. Related to an integrated palliative approach to renal care, and then discuss how these results of the patient interviews related to integrated palliative nephrology care will influence us as clinicians to improve care delivery to meet their needs. Next, please. So the purpose of the IPN project was to enhance the capacity of renal healthcare professionals to embed a palliative approach for patients with advanced CKD by changing culture, sharing knowledge, and developing resources to support clinicians to shift practice, resulting in improvement of care delivery. So what does a palliative approach mean? What does this look like in our day-to-day practice? So we've all heard the term renal patient. You might get a call as a nephrologist on call from the emergency department. Yeah, we have one of your renal patients here. So this is looking at the whole person, not just the illness. We care for patients living with CKD. And that's different from referring to them as renal patients. We're trying to identify and care for all of their needs, be it physical, psychological, spiritual, cultural, social. And I'm going to challenge each of you to reflect on your own practice and what this means for you and your patient care experience. And I'll give some examples. So we are identifying what brings joy to a patient and trying to enhance that. We are trying to identify what brings them distress and minimize that. What brings them joy? Spending time with family. Let's talk about how we enable that through planning for initiating a home dialysis therapy. I have trouble paying for my medications. I applaud BC Renal, Dr. Levin, Dr. Martin Newson for, pardon me. So that means BC Renal advocating for patients and enabling coverage of dapagliflozin, a very expensive medication. So those are just some small examples, but important. So this can be embedded and implemented at any time along the illness journey. And what we're advocating for is for us to think about implementing this further upstream in the illness journey, not simply near end of life. Next slide, please. So what were the goals of the IPN project? Enhance renal clinician engagement in advanced care planning, train healthcare providers to initiate serious illness conversations, which is part of advanced care planning, develop resources to help patients transition to end of life, and I'll also add to help healthcare professionals in their counseling of their patients transition to end of life, to assist with evaluations at the health authority level, and to forge and develop shared care partnerships. Pardon me, sorry. To facilitate dissemination and change practice culture. Next slide. I'll talk about what shared care partnerships mean. So the IPN had 3 different themes that we wanted to focus on. So we wanted to educate through training. We literally trained hundreds across BC, mostly healthcare professionals involved in caring for patients with CKD, but some others as well. So training them regarding serious illness conversations, also educating them about accessing the ESAS as a tool to assess and manage symptoms like pain, pruritus, insomnia, and there was a project that was spearheaded by Helen Chu, and we had a working group that also involved patient partners that guided us to improve upon the tool that was existing and to come up with new technology-supported enhancements, such as being able to download it in PDF form, completing it electronically, and then submitting it back to your clinic prior to your visit. We trained local champions, and again, that was through shared care partnerships, which I'll speak of in a moment, not just in the realm of the renal programs. For example, educating home and community care nurses about what resources we have for pain and symptom management and how to access them. We developed resources, and that included various documents for both patients and healthcare providers. And I will briefly mention that one of our patient partners who was instrumental in guiding us around development of one of our stopping dialysis documents, which involves frequently asked questions and actually has a checklist, so to speak, at the end of it. When she herself was at end of life, she used the very same resource that she helped develop, including going through the checklist, which involved finding a new home for her dog. The conservative care documents. So those of you who have patients that you care for in the kidney care clinic, this is one of the options when they go through modality education. Conservative care, what does that look like if you choose to receive supportive medical care to optimize quality of life without the plan that involves renal replacement therapy called dialysis or transplant. And then there's advanced care planning documents for healthcare professionals as well. And all of these can be found on the BC Renal website. And then dissemination. So these shared care partnerships I spoke of, that includes forging and developing a relationship with the BC Centre for Palliative Care. They are developing outstanding educational resources. I invite any of you to access their website. It was there that I found an educational a series of slides. It was a module, really, an educational module related to culturally sensitive advanced care planning. And it related specifically to Chinese and South Asian patients, and it was excellent. Another example is modification of the Serious Illness Conversation Guide for Indigenous patients, because there was a great deal of work done in members of the BC CPC reaching out to members of the First Nations Health Authority and showing them what the existing Serious Illness Conversation Guide is, and asking them, does this align with how you like to be treated? Does it align with how you want to be asked and approached about end of life and advanced care planning? And they provided some very helpful feedback. And I will point out later on that forging relationships, establishing a trusting relationship with Indigenous patients prior to embarking on a serious illness conversation is instrumental. Primary care providers, so our family physician colleagues, we reached out to them and made sure they were aware. Not listed, but I'll include that home and community care nursing, hospice nursing, hospice physicians, palliative care physicians, and locally I even gave a presentation to our house physician group. So just so they were aware of what resources we have and where to find them. And then, of course, renal healthcare professionals and nephrologists. So for part two, and this is a bit of a teaser, we'll talk about healthcare professionals' perception of the role of nephrologists. And I'll present a bit of a spoiler. We are referred to as the quarterbacks. So vitally important that the quarterbacks know about what resources exist and how to access them. Next slide, please. So what was our methodology? This was a qualitative research project, so a mixed method approach was used. And really, we wanted to know how well we did post-implementation of all of these things we did through the IPN, the education, the resource development, the dissemination. What was the result from both patient perspective and healthcare professional perspective? So we had renal care team surveys and interviews and focus groups. And what I'll speak to today and present are the results of the patient key informant interviews. Next slide. So the purpose was to evaluate patient understanding, knowledge, and perspectives of a palliative approach to renal care following implementation of the Integrated Palliative Nephrology project. Next. So our key findings. So as you can see, numbers were small. Certainly, I am a rookie when it comes to qualitative research, and really had underappreciated how much time is involved in not just preparing for and setting up interviews, but conducting them, and then reviewing in detail the recorded transcript afterwards. So you ensure that you capture accurately the patient's responses. So small numbers, yes, but resources are not unlimited, as we know. So there was the best representation from Vancouver Coastal Health. In terms of modality, most were from KCC, but some from PD and hemodialysis, and 2 transplant patients, actually. And so reflect on this when we mention some of the comments that patients made, because it may be because that some patients were fairly early in their illness journey, if the majority were from KCC. Next slide. So at the top of each slide, you'll see general themes and then the specific questions. So we wanted to know what matters most to patients, and one specific question related to this is, has your care team asked you what is important to you as you consider your healthcare decisions? So again, this is a palliative approach. We're asking what matters most, and 50% said yes. And so what did we learn? So it was a big reminder that there are factors external to their illness that are important for decision making. An example, never more influential have been social determinants of health. I don't think anyone would disagree. Our dietitians and pharmacists are vitally important in the way they practice, and they are using a palliative approach. When, for example, one of our lovely dietitians makes sure one of my patients has 2 weeks worth of liquid nutritional supplements, whatever's available, because she runs out of money to pay for food halfway through the month. Dan Martin-Newson does medication reconciliation, advises me to de-prescribe expensive medications to make things more affordable, tries to, whenever, ensure that the medications that are BC Renal formulary supported, that I switch to those. That's a palliative approach. Those are factors external to their illness that may impact their level of distress. Preparedness for the future was important to our patients. And again, strong relationship with the care team based on respect and frankness. It's a small thing. So this was a patient quote, direct quote. It's a small thing that's not always possible, but having members of the team know who I am and to address me by name, that made it feel like it was less clinical than it was. Like, just that it was more open and friendly. Next slide. So tips that patients gave for a better discussion. So they did point out, and we're realizing this more and more, that the beginning of the CKD journey, whatever stage you're at, maybe it's early on, but your patient feels blindsided. They feel fine. What are you telling me that, my kidney function is 30% of normal? What do you mean by that? They're distressed by that. They're given this package of information. It's overwhelming. They may not retain it. They want more information, but they want it sort of in chapters, so to speak. So instead of handing them the full volume of Tolstoy's War and Peace, you're giving them chapters at a time. Have more discussions around different possibilities and what a person should expect. Use a gentler approach. I think this loops back to piecemeal information provision, multiple points instead of the bolus, as we call it. Some more quotes. I didn't know that was available. I've been told you need to be on dialysis because your kidney is not functioning and that you need to get a transplant. I didn't really have a choice, so it was a life-altering decision. I stopped working because the dialysis took a tremendous amount out of me to this day, and I was suffering from headaches and fatigue, and I couldn't work anymore. Another, earlier on, it would have been good to have somebody else with me because I was so sick. Cognitively, I wasn't comprehending or retaining information really, but when I was in the hospital this fall, there was like no visitors in at all, zero. So reflecting on how isolating it can be, not only to be physically isolated because of COVID, where no visitors are allowed, but here you are blindsided by what seems like a new diagnosis, even if it's not, even if it's a planned dialysis start. It's a huge transition. Having to stop work has a serious impact on people psychologically, spiritually, financially. Next slide. So the next thing is life-sustaining treatment. And yes, indeed, dialysis is long-term life-sustaining treatment. Believe it or not, some of our patients don't realize that until you ask them the question, well, what's your understanding of what would happen if you stop dialysis? It's an interesting question to pose. Have you thought about what life-sustaining treatments you would want? So that ranges from full CPR, defibrillation, intubation, mechanical ventilation. That's the classic. If you have a cardiopulmonary arrest, what would you like us to do? But dialysis is factored into that. So the vast majority of patients asked have thought about it, and the emotions they experience when discussing their wishes with others, and others means anyone, not just healthcare professionals, their loved ones, people who are important in their lives. Nervous, afraid, glad, a bit relieved maybe, discomfort. They were easier when the interviewees had previous exposure to palliative care through other family members, so they knew a little bit what to expect. They had the same philosophy on death as the person they were discussing their wishes with. Familiarity with the healthcare industry, so they know how the system is navigated, so to speak. They had open relationships, long-standing relationships with these people, and they had access to counseling. Those who did not discuss their wishes with others said that it was just general hesitancy and fear of the unknown, fear of response too. For instance, if they were speaking with a family member who really wasn't open to the idea that their loved one was thinking about stopping dialysis, and they knew they were going to get some resistance to that, they would be a bit hesitant. Next slide. Has a doctor talked to you about the benefits and burden of life-sustaining treatment? So this response was the minority, despite the fact that most have thought about it. So, but again, reflecting on the fact that the majority of our interviewees were KCC based, they felt the conversation wasn't really necessary based on their current medical state. I think at the time it would have made my situation feel more dire than it really was. I'd like it to take place when there's some evidence that concern that it may become relevant. And this does reflect on the readiness of patients. And so I'll speak at the end about, considering using a tailored approach when we determine when is the right time. And again, you don't know unless you know your patient well and have that relationship. Next slide. Has your care team discussed supportive care services such as palliative and spiritual care in case of a life-threatening illness? Again, the majority said no, but as many reflected, they would like to. Again, another quote, I was in severe pain and I thought, oh, this is the end of me. Plays a lot on the mental health and support in that aspect I feel is needed. And they do try to support you. So there's acknowledgement that we do try, but the time issue, they can't sit there and give you counseling for hours on end and talk about it. So it's interesting how there's sensitivity on the part of patients about our time constraints, but they do appreciate us trying. Next slide. So do you have an advanced directive or living will describing the medical treatments you would want and not want? Half said yes. And the reasons for proceeding with that they witnessed a loved one passing away, and they reflected on that, and particularly if that loved one did not have their wishes documented, how that then reflected on the distress, the level of distress that, for instance, substitute decision makers were in when they were left with making decisions on behalf of their loved one. Existing medical conditions that are independent of kidney disease. So we fully realize and acknowledge that many of our patients won't die directly because of their end-stage kidney disease. They'll succumb to something else, a cardiovascular event, sepsis, for example, a malignancy. Perhaps on the advice of the lawyer, and protecting their children came up as well. Interesting. They wanted to, again, alleviate the stress that their children might experience in the event that end of life came surprisingly sooner than predicted. Reasons for not documenting, we're human, we like to procrastinate about things that aren't all that pleasant. Just general hesitation, perceived irrelevancy, again reflecting on the fact that they didn't think it was necessary based on their current health condition, and it just hadn't ever been brought up with anyone. Next slide. So of the resources we developed, we wanted to know which of the what percentage of the patients were aware of them. And unfortunately, only 6 out of 16 were aware of them. So again, reflecting on this is a clear message to us that we, across the board as healthcare professionals, first of all, we need to be aware of what the resources are ourselves, and then ensure that our patients know that they exist and to access them. So which ones did they access? The vast majority, well, all the 6 had looked at stopping dialysis treatment, and the advanced care planning wallet card, frequently asked questions about stopping dialysis, transitioning to conservative care, and talking with your clinician about the future related to advanced care planning, and again, talking about your illness with loved ones and caregivers. So they felt that the quality of the resources was very good. They were thorough and well prepared, used plain language, and had important, relevant content. But suggestions for improvement, of course, we can always do better. Knowing what to look up and where to find it, more visual or verbal content, so incorporating technology such as video links to videos, infographics. A couple felt that the information was quite overwhelming, and again, getting around to what people are comfortable with in terms of the terminology, so retitling the resources to make it friendlier. Again, everyone's different in their perspective, calling for somewhat of a customized approach. Next slide. So additional suggestions for improvement. We should understand the impact of kidney disease on other parts of the body, and patients want to know what to expect. This caused me to reflect on my own practice and ask myself a question: how often do I give this information at sentinel points along the illness journey? For example, when one of my patients is initiating renal replacement therapy, have I informed them about what to expect? They may not ask. It doesn't mean they don't want to know. And we should be sharing what the benefits of a palliative approach to care are. So one quote, this individual wanted to know what they could do physically. I didn't know if I could do an hour's worth of shoveling, and yeah, no one seemed to give me any answers at the time. Just something about what a person can do physically, even if it just says you could do everything. There was lots about eating and what you can eat and not eat. Reflection on last week's province-wide rounds that Danny so skillfully delivered, and I was so appreciative for her focusing on patient quality of life, and again, that's a palliative approach, is finding out what matters most to a person about the food. But they also want to know what you can do. So again, a reflection. How many of you have heard the question from a patient, when am I going to feel better? So that's a hopeful question. Then the next, further downstream in their illness journey, not so hopeful, maybe more desperate. Am I ever going to feel better? And what's her answer? Do we dodge the question and respond with something vague like, well, it's unpredictable? That just is a reflection of our own level of discomfort. They want us to be honest. Once a person is in that situation, they should be made aware of some of the consequences that could happen. The person does not have certain things in place, but you have to know what those certain things are. The will, for example, that is something that we should all want in place, no matter what age, because anything can happen. Next. Most interviewees were satisfied with their care experience related to a palliative approach. Again, they informed us as to how we might improve. We're all very familiar with the very busy in-center hemodialysis unit, and community units can be just as busy. Alarms going off, there's no privacy. It can be very intimidating and scary. And there's others listening in. You don't necessarily want them to know your deepest fears, and it can be difficult to, again, maintain a trusting relationship when you're asking them to speak from their heart, and there's other people listening in. They want to have confidence instilled that there's communication between different departments and different healthcare professionals. So, for example, are you talking to my cardiologist? Are you on the same page? What about my family doctor? Are you talking to each other? I'm getting different messages, mixed messages. So this is important too. Include advanced care planning as part of the timeline for what patients can expect. And caregivers, well, the patients, they actually, some of them expressed a concern for their caregivers that they would become a burden on them. And they wanted to know, would there be any opportunity for respite care in the event that their health took a sudden turn? Next slide. So key messages for the care team, that's all of us. So these results illuminated that many care teams have not discussed patient wishes for care, particularly the benefits and burdens of life-sustaining treatment and availability of supportive care services. Many patients think about their life-sustaining treatment preferences and have living wills or advanced directives in place. Next. Patients are open to receiving this information, but they prefer it be communicated at several points in the care journey. So again, the analogy being the small chapters at a time instead of the bolus all at once. They're generally satisfied with the palliative approach to care and feel the appropriate amount of information has been communicated with them given their current medical state. Next. And I, with gratitude, acknowledge the 16 patients who participated in the evaluation interviews. Is a great deal of time and energy, and in fact, some of these questions may have been triggering. When we think about discussions around end of life, the analogy, after reflection on a quote I saw the other day, it's the thorny bush of the care we provide. It's a thorny bush. But if we strive to embed a palliative approach, that's like the roses on the thorny bush. And so I think we should strive for this because patients want this. They've expressed what they want. So renal program healthcare professionals and nephrologists who facilitated engagement with patients, I'm grateful to them. They are the ones who actually were vitally important in having us gain access to patients for these interviews. Yancy Rajmohan was our project manager, very grateful to her, and Sue Saunders and Salma Wadwania, part of our leadership team for the Palliative Care Committee for BC Renal. I'm always grateful for their feedback and direction and guidance. And Selma was instrumental in coordinating and communicating with patients and setting up the interviews and all of the behind the scenes work, the time and energy involved. Sarah Thomas will be ever so grateful for a long, long time for her skillfully managing the IPN project. Selena Shao, biostatistician for BC Renal, who is instrumental in putting together our quality metrics for MESAS and ACP every 6 months. Courtney Bell, who served as interim admin assistant while Selma was on maternity leave. Next. So this is a summary of some of the resources, and they can be found navigating through the BC Renal website as the first bullet states there. And I would invite any of you involved in educating our clinicians of the future in every discipline make sure these trainees know about the BC Renal website. I shared this with a fourth-year medical student recently, and her comment was, "Wow, this is a gold mine." The Ariadne Labs website, that's where you can find all resources related to the Serious Illness Conversation Guide. The BC Center for Palliative Care, again, really a gold mine for resources there, and HealthLink BC. So I would be happy to field questions, comments. One last, I guess, analogy or personal reflection I have is on September 29th, or 30th rather, pardon me, I had the opportunity to watch from start to finish an interview with one of our local Indigenous champions for survivors of residential schools. And this was on the National Day of Truth and Reconciliation. Eddie Charlie, truly inspiring. He conducts these interviews several times a year, and extremely inspiring. And he does this while being very hearing impaired. Each time he answers questions, by observation, it's triggering for him because he is a survivor of the residential school system himself. The interview I watched, the journalist asked him, "Why do you do this?" Because it's challenging for you, obviously. And he said this: "My goal is to ensure that the survivors of the residential school system don't just survive, that they really live." So I thought that is like my goal, that I should want my patients living with CKD to not just survive, but to live the best quality of life they can. Thank you for your attention. I'll invite questions, comments at this time.
Thanks so much, Gaylene. And I think it's so important for us all to sort of think through it and digest all the things that you've brought to us. I believe that most that people do try very hard to take this holistic approach, but I think sometimes time gets in the way, or without being reminded about these fears and what people are anxious about, and how we give information, I think there's always the potential to slip. So I think you've really given us food for thought. I'd like to ask others that, like, there's 35 of you on the call, so I'd love for other people to ask or answer questions in terms of or share experiences. While people are gathering their thoughts, I was going to say, the other thing that resonated a lot with me is people want you to be honest with them. I've never had anyone say, "Don't tell me stuff." We sometimes hide things or don't tell them the whole truth. And I think that people have a spidey sense, and they're intuitive, and they know when you're holding back something. So I do believe that giving kindly, but whatever you know, and when you don't know, I think it's okay to say, "I really, really don't know," and that they appreciate that. So I find that is another way to establish trust and relationship with people. And I also, the other thing that resonated is the regularity of the interaction with the patient, so that they get to know and trust you, is really important. And I get quite frustrated when I see people asking important life decisions at 2 o'clock in the morning to a stranger in the emergency room. No wonder people answer yes, that they want everything done because they think that they answered wrong. This is the thing that happened with us, all the work that the dialysis team has done with all of our dialysis patients. And then they come to emerge at 2 o'clock in the morning, and somebody asks them again, even though they've had this conversation. And then they say to us afterwards, I must have given the wrong answer. when I was in the dialysis unit because they asked me again. So then I changed my answer. Like it's so complicated. And I think the more we're aware of this and have a place to talk about it, I think the better, we all become at it. And refraining from asking difficult questions at 2 a.m. to strangers is an important lesson to remember. There's a question. Thanks for the presentation, Gaylene. What's next in addressing the improvement opportunities identified from the interviews? That's a Helen Chu question.
Love it. Yes, and so we actually had our annual longer palliative care committee meeting just yesterday, and I'm again so grateful to BC Renal for granting me not one, but two highly capable, passionate, motivated vice chairs. And one of our vice chairs, Sherry Kensel, is going to focus on our education strategies. So, and again, a bit of a spoiler for part 2 that's coming next month, but it was reflected in this, that there's a lack of awareness that the resources are there, right? If only 6 of 16 patients know about the resources, then how are we going to improve upon that? And so we need an education strategy. We need to identify what the influencing factors are. We all recognize there's been really high staff turnover, right? And so we've had sort of this this exodus, I'll call it, of seasoned staff, right? Retirement or moving on to other areas, and an influx of new staff, and they are keen to learn, right? It's not that they don't want to know, whether it be time constraints or we're busying ourselves with all of the other things on our to-do list in a day, but we're forgetting that their onboarding education when they start is important, and part of that onboarding education is informing them of what resources are available, so that, for instance, when it is daunting for instance, a brand new dialysis nurse to be caring for a patient who blindsides them with, I can't do this anymore. I've been thinking about stopping dialysis. And you can see when I'm rounding, I see the fear in that healthcare provider's eyes. There's just, oh my gosh, what do I do? Education, knowledge is power, right? So it's our responsibility for those of us who develop these resources to enhance awareness. So I hope that addresses the question.
Yeah, I think it's like all things, it's spread and scale, right? It's like, how do you spread and scale stuff that in some ways people do intuitively well or not, and could do better with tools? And then how do you make sure that everybody understands? And I think, we often, I think most people that are 80 something or 85 or something, they know they're going to die, and we're all afraid to talk to them about it. Like, they got there. So like we should, not remember and respect that these people are fully aware that they are X number of years old and may not live for. So it's us that's afraid to talk about it more than them sometimes, right?
Absolutely. They've already talked about it. They have, most of them, of a certain age, have, either wills and or advanced directives in place.
Right. There is another question. I just want to make sure I get to it. So really thoughtful question from an anonymous person. Moving forward, how do we integrate other healthcare providers for those that live more rurally, especially people, internal medicine, geriatrics, palliative care? How do we provide home visits with the sort of home care staff? And then another one about peer support groups at hospitals, and would that help? And dialysis units. So two different things.
I love the comment about peer support groups, because patients have told us that having the ability to talk to other patients with a lived experience helps with the what to expect question, right? Of course, everyone's different, they're gonna have a different experience, but it gives them some general idea, right? So, and then the rural and remote, again, Sherry is doing a deep dive into the current state. So what are the current gaps? How does it vary region to region within the province? And how, because there are some geographically remote areas that can actually still manage pretty well, but they've made adaptations. For example, in a rural remote area, a primary care provider is going to ensure that they feel confident and capable in delivering palliative care, right? Locally, I spoke the other day to one of my primary care colleagues who still makes home visits. And in rural and remote areas, they do still do that. It's something that we're like, that's a bit of a foreign concept to those of us who work in urban centers, right? So let's capitalize on what they're already doing, identify gaps, and then identify creative ways to bridge the gaps. It's not an insurmountable challenge. We just need to be creative.
Yeah, I think recognizing that it is different, but doesn't mean you can't do it. I think that's great. Carolyn has her hand up. Carolyn, did you want to ask a question?
Yeah, can you hear me?
Yeah, perfect. Thanks.
Oh, perfect. Hi. Yeah, thanks so much, Gaylene. I think you addressed actually in the last answer where I was going, and I'm trying to turn this into a question, but it's kind of a comment that I think we spend a lot of hours, and I hope we're successful in getting patient trust, because I agree. I think trust is really big, that things are going to be okay for them. And we encourage our patients to call if they need something, but then that connection to home and kind of that hands-on care and that really responsive care that's needed for patients and family members as symptom complexes escalate is, I think, the toughest part of this type of care for me anyway. And I find that it's a big area where we work hard to establish trust, and then that needs to follow through. And so you've addressed this in part, and maybe this is the best we can do, but I think that link to home and community care, to primary care such as it is, and the help that we need at the home level and as things intensify. Absolutely.
Thank you for your insightful, thoughtful comments, Caroline. One thing that came up, I attended a really helpful webinar related to cultural sensitivity in having advanced care planning discussions, serious illness conversations with Indigenous peoples. One messaging that was very clear was, if you say you're going to do something, follow through with it. Well, I mean, really anyone doesn't respond well and remembers the times that you did not keep your promise, that you did not follow through with something that you said you were going to. So we have to bear that in mind. And sometimes it's actually the little things we do along the way that really develops the trusting relationship. A small example this week was one of my home dialysis patients came in for parathyroidectomy, and I thought, oh, well, you know, I tried to find out where he was in the system. Oh, yeah, he was out of the OR and in the recovery room. So I called up to recovery, spoke with his nurse, asked if would it be okay if I came by there? And she said, oh, yes, by all means, he's awake. And so I did, and you know, just made sure a med rec was done and that the PD orders were done and all lined up, and then I had my student follow up with him, fourth year student follow up with him the next day, and so I asked her, well, how's he feeling? her response, he feels safe and well cared for. And when I went back the day after that to see him, he said, you seeing me in the recovery room was really special. And I didn't even think, like, I didn't think anything about it. I was just kind of ticking off a checkbox, making sure the orders got done. But it's sometimes those little things that are really meaningful to patients. They want to feel safe. Especially when they realize they hear on the news every day about short staffing and the impact that may have on their care. They worry, I think, about things slipping through the cracks. If we're not perfect, and they know that too. They're sensitive to the stress we face, and the limitations, but they just feel really confident to know that we're trying our best.
Yeah, I think that's a fantastic note to end on. It is about caring for everyone. It's about being present and treating people like people, right? And they're not just a number, and they're not a patient, they're a person. I think that came through loud and clear in the interviews and in this. So thank you for putting all the work you do and then putting together such a poignant presentation. I think it's given us all food for reflection and thought. And thank you. Look forward to part 2. And thanks everybody for joining.
Thank you, everyone.